Hello and welcome to Health Check from the BBC. I'm Claudia Hammond, and for the next half an hour, I'm here to fill you in on the latest news from the world of medicine and health. In a moment, a new microgel designed to make surgery safer for babies. And Mexico announces the creation of a universal healthcare service. We'll hear how just getting a population of 130 million registered is quite the challenge. And joining me today from Boston University in the US is my guest for the whole show, Matt Fox, who's Professor of Global Health and Epidemiology. What do you have for us today?
So we are going to try to get to the bottom of whether these new Alzheimer's drugs are effective.
We'll have more on that later, but we're starting today with an invention. An injectable microgel designed especially for babies to make surgery safer by reducing bleeding and the need for blood donated by adults. It's been developed by Ashley Brown, who's Professor of Biomedical Engineering at North Carolina State University and UNC Chapel Hill. It is early days at the moment, but it is intriguing, and so I asked her to tell me more about this new material that her team has designed.
At a high level, the material that we have designed is a injectable material that can stop bleeding. We have designed it specifically to stop bleeding for babies. The reason that we are interested in developing a material specifically to stop bleeding in babies is because while we don't necessarily think about babies bleeding frequently, certain populations do end up needing blood transfusions, such as babies that have congenital heart defects that require surgery early in life, or extremely premature babies that are very sick may require transfusions. It turns out that those patients, they receive blood transfusions to deal with the bleeding problems, but those blood transfusions are with adult blood products. Those adult blood products can actually put babies at high risk for thrombosis or unwanted blood clots. And so we've developed a therapy that capitalizes on how babies clot, which is a little bit different than how adults clot. And that material could decrease potential risk for babies that have problems with bleeding.
That's really interesting that a baby's blood clots in a different way from an adult's.
Yes, so there's a number of reasons that babies clot differently than adults. In your first year of life, many systems within your body are developing. This can be protective when the baby's in the womb, but when it comes to clotting, there are a number of different factors that vary really early on in life, but continue to develop as children develop and get older. So some of those include key cell types involved in bleeding. So platelets, for example, are a primary cell type involved in clotting. Those act a little bit differently between babies and adults. And what we are particularly interested in my lab is differences in a protein known as fibrinogen, which is the main protein that is involved in forming a blood clot. And it turns out that there are differences in that protein that alter how clots are formed compared to adults.
And you've developed this new gel that you would actually inject into the baby. What is it?
It's a hydrogel, which is essentially a polymer that has really high water content. So we come across hydrogels quite frequently in our everyday life. So if you've ever had Jell-O, that is a hydrogel. However, the material that we are making is a microgel. And so what that means is that we're making hydrogels, but on the micron scale. So these hydrogels are the same size as those platelets that I mentioned earlier. And so we're able to mimic some of the key aspects of platelet interactions with that protein, fibrin, and clotting. So the hydrogel microparticle that we have developed, we decorate it with a peptide that allows for the microgel particle to specifically bind to injury sites by interacting with the fibrin protein. That's the key protein involved in clotting.
Oh, so it finds its way to the right place in a way and to do the right job.
It does, exactly. So we're able to inject those particles and it goes straight to the site of bleeding and injury because we have put peptides on the surface of the particle that allows it to bind to fibrin at sites of injury.
So how effective is this material? I mean, has it been tested in real life situations?
So we have tested the material both in the lab in human plasma samples. So plasma is blood without the cellular components. So we've tested the material both in human samples in the lab as well as in a mouse model of bleeding as well. So what we've found in the human samples in the lab, we found this material to be quite effective in samples that are collected from neonatal samples. So we've seen that the particles are able to enhance how quickly clotting occurs in the lab. We have also seen in the animal model that we can decrease bleeding after an injury by 50 to 60% compared to controls.
So if this is successful in the future, what kind of difference could this make, I don't know, in places where perhaps stocks of donated blood are low? Could it be used for anybody?
This product could make a really big difference when there are low stocks of blood. So that's a pretty pervasive problem across the world, is having limitations in stockpiles of blood and also the ability to transport blood. And so in those situations, this product could absolutely make a difference. I will point out that this particular design is aimed at interfacing with the clotting system for babies. So it's designed more specifically to help clotting in babies. But my lab has also developed versions of this technology that work quite well with adult samples. And we have been working on scaling that technology up specifically to be used in adult patients.
So in a way, would this be an alternative to a blood transfusion? Or would you give people some blood and give them this or the similar one that your lab is making in order to help the blood clot?
Our ultimate goal would be to replace blood and have this be as a complete alternative. I think in reality, what's more likely is that this product would be used in conjunction with blood transfusions, but even that would potentially make a massive difference in alleviating the amount of blood products that are required to stop bleeding in patients.
Professor Ashley Brown, and Matt Fox is still with me. Now, every so often, Matt, there is a mystery disease that worries health officials, and this time it's in Burundi. 44 people have become ill, and of those, 5 have died in the Mpanda district in the north of the country. Now, Matt, the symptoms are fever, vomiting and diarrhoea, which can be caused by lots of different diseases. What's been ruled out so far?
Yeah, it's concerning. So far, they've done some testing and ruled out a number of the various viral hemorrhagic fevers. So these are the ones that cause severe bleeding. So things like Ebola and Marburg and Rift Valley fever, as well as things like yellow fever and some other hemorrhagic fevers. So those fortunately have been ruled out.
Now, when we've covered mystery illnesses like this before on Health Check, sometimes it turns out in the end to be malaria. Could that be the case here?
It certainly is possible. I would say it's probably unlikely in this case, but it is possible. And the reason for that is malaria is a challenging disease in that sometimes it can go undetected, but more often what happens is because malaria is so endemic in many places, people can test positive for malaria, but that may not actually be the cause of a disease. So it's often tricky to sort out whether malaria is or isn't the cause of some severe illnesses that cause fever.
And with this one, the WHO is saying that it's caused 5 deaths and made 44 people ill. Is that something that could happen suddenly with malaria when you get an outbreak?
It could in theory. I mean, more likely what's happening in cases like that when it is malaria is that it's just coincidentally a cluster of cases that happen to all be severe that came together, and it looks like something else. More often than not, though, malaria isn't going to cause a large number of unexpected deaths. And so they certainly want to continue to look for other causes.
Yeah, so how do they do that? What are the steps that they need to take to start to identify an unknown illness like this?
Yeah, the main things that you do is you start running tests looking for everything that we think of that can cause illnesses like this. So to try and really rule those out, occasionally these things are caused by new viruses and bacteria that we haven't actually identified before. In those cases, it's much harder to actually determine the cause. So really the focus is on identifying and ruling out the things that we do know are possibilities.
And of course, the reason that now everyone is alert to any disease that's hard to identify is after experiences with Ebola and, of course, COVID. Does this bear any similarities to the starts of those outbreaks?
Well, it does in the sense that this is a cluster of severe cases that we can't actually identify the initial cause. But this looks a fair bit different in that it doesn't seem to be, at least at the moment, be spreading much beyond the area in which the cases have been identified. And obviously that's a good sign.
And here on Health Check, we'll keep following that and we'll let you know if there are any updates on what's happening in Burundi. You are listening to Health Check from the BBC. I'm Claudia Hammond and my guest today is Professor Matt Fox from Boston University in the US. Now, people may have heard in the news last week that a review of more than a decade of trials into the newest Alzheimer's drugs has concluded that they have negligible clinical benefit. The review was from the Cochrane Collaboration, who are very well respected, but some other experts have criticised the analysis, saying there is evidence that some of these treatments work. So, Matt, we thought we'd take the opportunity of you being here to try to get to the bottom of this. So, first of all, what did the Cochrane Review set out to do?
Yeah, the Cochrane Review, they take all of the studies that have been done on a particular topic and try to bring them all together to draw some conclusions. So in this case, they looked at 17 different studies on these drugs that are targeted at amyloid plaques, these plaques that we think are leading to Alzheimer's, mostly in patients with mild dementia at this point. And they looked to see how effective these drugs were at slowing the progression of the disease. So focused on things like cognitive function, dementia severity, and people's ability to engage in daily activities of life. And it was a large study that had over 20,000 people in it. So it really is the best evidence that we have to date.
And what conclusions did they draw?
Yeah, this was the troubling part, is they concluded the drugs really were not very effective at improving the different outcomes that they were focused on. So really no benefit in terms of slowing cognitive function, in terms of dementia severity, and really little or no difference in terms of functional ability. They also found a little bit of an increased risk of some adverse events, some of the things that you'd be concerned about as side effects of the drugs, though in most cases they really didn't lead to anything too severe.
So if that's what the trials found, why are many very reputable experts in the field criticising these conclusions?
Yeah, and I should say I share some of their concerns. The reason for this is they took all of the drugs that they've been using to try and target these amyloid plaques and put them all together in one group. And the problem with that is these different drugs, they target different mechanisms by which you would be slowing the progression of the disease. And we already knew from some of the trials that have been done that a number of these drugs were ineffective, whereas a few of them did show some promise. So when you take a number of drugs that we know don't work and you average them together with the effects of drugs that we think could work, on average, you're going to end up looking like there's no effect, when in fact, you really shouldn't be putting all of these different drugs together.
So if you just take the drugs that show more promise, there's one called donanemab and there's one called lecanemab, how much difference do they make?
They made some difference. So they modestly slowed the pace of cognitive declines for people who were in the early stages of disease, which obviously is beneficial. But these are pretty expensive drugs at this point, so we would certainly be hoping for larger effect sizes.
But what is your take on this? Where does that leave these drugs? Will they be abandoned?
I don't think they're going to be abandoned. People are desperately looking for ways to slow down the progression of what is a really horrific disease. But at the same time, the cost is going to be prohibitive for some people. And the limited evidence that we have of strong benefits means I think we're going to have to continue to look for new avenues to pursue to slow the progression of disease and hopefully at someday to find something that actually reverses the effects.
Thanks for that, Matt. To Mexico now, where the President, Claudia Sheinbaum, announced the details of a plan to introduce universal healthcare. No mean feat in a country of 130 million people. To find out what the system will cover and what the reaction's been on the ground, I spoke to health journalist Katie Silva, who's based in Mexico City.
So it's a huge pledge. President Claudia Sheinbaum's government said that they will guarantee that the entire population will have access to healthcare by 2030. So Mexico currently has multiple public health systems that run in parallel, and they're tied to a citizen's employment status. So it's a different system in hospital or healthcare centre, for example, if you're a government worker or you're employed in the private sector or you're employed informally, that's cash in hand, or you work for the state oil company Pemex. And the idea, in a way, of having these differentiated systems in a country like Mexico, where more than half of the labour force is informal, it was designed by the government to incentivise people to enter into formal employment by tying their health coverage to it. But now they want to roll them all together into a single universal healthcare service so that people can use any public hospital regardless of which system they belong to or their type of employment.
Is it complicated then, the way people get care at the moment? Does it mean you can't necessarily, go to the easiest place?
Absolutely. So one health professional I spoke with said, for example, you might have an MRI scanner on one side of the city and your centre there doesn't. And so you'll have to therefore travel, or there can be a lot of wastage as well, long waiting times and bureaucracy because you're waiting at your centre where all the doctors are occupied, and therefore you can't go to another one that might be just down the road and free or available. So it's certainly a big significant change. When it was first announced, we heard, for example, one of the directors of these services saying that it would give Mexico one of the largest universal healthcare systems in the world. There's about 53 million people here who don't currently have Social Security, they work informally, and now they're going to have this equal access to healthcare like others.
And in the past, Mexico has been well known for its public health, hasn't it? And I can remember, for Health Check, in fact, going to Mexico City back in 2006, and there were all sorts of new plans they were having then for how to improve things.
That's right, yeah. So for decades, Mexico was seen as basically a standout in Latin America for building one of the most effective public health systems, particularly, for example, its vaccination programs, which were among the strongest in the region. We saw near universal childhood coverage, and of course there's been this measles outbreak now, and many say that because of the downgrade that we've seen in public healthcare systems here, particularly as well in vaccinations, that's what's caused it. Certainly things have very much gone downhill. So Roberto Jordan, who's paid cash in hand as a dog walker in Mexico City, he described his frustration with the current system.
As someone who actually uses the public healthcare system in Mexico City, I think these changes are necessary. Right now, dealing with the system is a nightmare. It's full of bureaucracy. You get sent from one place to another with no clear answers. It's so frustrating. People avoid going unless they really have to. But as you get older, you can't ignore your medical ailments anymore. You need care. Things start hurting, and you have no choice.
So why have things seemed to have gone downhill a bit recently?
You mentioned, of course, how there was that really lauded system. It was called Seguro Popular, and it came in about 2004. It aimed at achieving universal health coverage for about 50 million people that were uninsured, providing public insurance to informal workers, reducing the cost or the out-of-pocket expenses, and improving health access. But through a series of downgrades, it was defunded significantly, and in the end, it was eventually gotten rid of by the former government in 2019. Now, Maria Rosario Lombera is a lawyer that specialises in labour and social security law with the consultancy firm Baker McKenzie. She says that abolishing Seguro Popular in 2019, just before the pandemic, was devastating for Mexico's healthcare system.
This left 36% of Mexican individuals without medical protection. That was an absolute disgrace for the country. That triggered bigger impact of the pandemic than what would have expected if those services were still in place. So it was a real tragedy.
So what's been the reaction locally to now having a more ambitious health system, by the sound of it, than before?
Well, generally, people I've been speaking with are supportive but sceptical. So the idea of universal access is broadly popular, especially among people like Roberto who work in the informal sector. They've long struggled to get consistent care. But Mexicans have seen all of this before, and there's definitely caution about whether the system can actually deliver. So nurses I've been speaking with, for example, in my reporting, have talked about persistent shortages of doctors and medicines and equipment. And there's questions about whether this rollout feels rushed and unclear, and particularly after that disruption caused by scrapping Seguro Popular. Now, in general, I'd say supporters argue that it's a necessary step towards equality. Detractors say that it's going to be potentially cause longer waiting times and strain on an already stretched system. And they've also seen as well a lot of posts on social media from up north in the US exclaiming basically how Mexico has achieved this when at the same time in the US we're seeing President Trump scrapping Medicaid.
And I guess just in terms of the admin involved, 130 million people is a lot of people to get into a new system and link up all the hospitals somehow.
Yeah, it's a huge process. So one of the first steps to see whether or not this can work is to basically register the entire population into that single system, as well as issuing cards that people would use to access the health system. So earlier this month, we heard from the government saying that they're going to start registering people now over the age of 85 to this new system. They want to achieve that by the end of this month.
And then what will be the first services to be made universal? And will people just be able to turn up and have those for free?
Yeah, so they're going to do it in a relatively phased way. So they say, for example, that by next year, they'll start with services that are already considered universal, but that's currently unevenly provided. So they're things like emergency care, maternity emergencies, heart attack and stroke protocols, vaccinations, and primary care. They also say that by January they want what's known as an exchange of services so that patients can use each other's hospitals, but that require that patients are registered. So hence that push now, as well as the ability, and this is going to be one of the really tricky bits, to share data between institutions. And it's a huge population, very fragmented services. Getting the tech up to do something like that as well is very complicated to implement. Here's health policy consultant Beatrix Martinez.
It must be understood within the context of the country we live in, a country of nearly 130 million people with a vast territory, great cultural diversity, and significant geographic variation, including rural populations. Not all health institutions have the same technology or resources, which makes implementing this strategy complex.
So is it feasible in your view? Will it be quite quick, or is this going to take a very long time?
So a lot of challenges, and I don't want to be a skeptic. It's certainly a tall order, especially because there's a medical system here that's already struggling to cope and now they're trying to step it up. But if the Sheinbaum administration can do all of this by 2028 or 2030, which is the end of her time in office, I'll certainly be very impressed, Claudia.
Katie Silver talking to me from Mexico City. Matt, I want to ask you about an experiment that was done by academics to see if they could trick AI chatbots into believing in an entirely fake disease. Now, it sounds as though this worked in a way even better, or worse maybe, than expected, and the bots started spreading misinformation about the disease, and other researchers even included it in their scientific papers. So what was the disease they invented?
Yeah, they invented a fake disease that was an eye disease that was caused supposedly by exposure to blue light, causing your eyes to turn a slight pinkish hue.
And they called it Bixonomania, so that doctors would know this wasn't a real disease because it wouldn't have had mania at the end of it if it was a kind of skin eye disease. But why did the researchers do this? What were they trying to find out?
So they were trying to understand if AI programs would pick up the information that they had put out there on blogs and on preprint servers. So these places where scientists put information that has yet to go through the peer review process, but is still seen as important to get the information out. They wanted to know whether the AI programs would pick up that information and tell people that this was, in fact, a real disease when people told the chatbots about their symptoms and if they had symptoms that were similar to this particular condition.
So it seems they were tricked. What happened?
Yeah, they were tricked, which is concerning. So they found that a number of the chatbots would tell people that their symptoms were a sign that they could, in fact, have this condition. In some cases, that would happen even when the person asking the question didn't say, do I have this particular condition? They just listed their symptoms. Not all of them did, but a number of them did. And that obviously is really concerning.
How come this fake disease then got mentioned in scientific papers as well?
We don't know exactly why, but this is a case where, it's potentially possible that what's happening is the AI chatbots are picking up this information. And then when researchers are trying to just generate some information on some of the background information for their papers, they ask the AI to help them, and the AI produces some citations. Another possibility is that researchers actually read the preprints that were put out there. So we don't know for sure, but either way, it's concerning when it's making its way into the published literature.
Yeah, what sort of implications could this have?
Well, I think it has the potential to signal that misinformation is quite easy to get into these chatbots. And as more and more people rely on them for all kinds of things, but including medical diagnoses, it suggests that these systems really need to be checked and trained in ways that don't actually reproduce misinformation, especially as we're in an era where misinformation around medical conditions is becoming more and more common.
And have any of the AI creators responded?
Yeah, so Nature is actually saying that a Google spokesperson said that these kinds of results reflected the performance of an earlier model, and that they provide prompts that encourage users to double check information, and that in this case, Gemini recommends users consult with qualified professionals. Microsoft did not respond to their request for comments, but it does suggest that the AI companies are actually taking this seriously.
And what do you make of the idea of doing this study at all? Are there ethical concerns about planting the seed out there of something that's completely fake?
Yeah, I'm pretty mixed on this one. I definitely have concerns because when you do something like this, when you put information out on a preprint server, you are actually attesting to the idea that this is true information. On the other hand, we do actually need people who are testing these systems to figure out what kinds of misinformation they're producing. So on the one hand, it seems to me it's really important research. On the other hand, it is concerning that researchers would be putting this information out there and nobody would know until the experiment was over.
Well, thank you so much, Professor Matthew Fox, for joining us for Health Check from the BBC today. And thanks to the producer, Jonathan Blackwell, and our studio engineers today, Yasmin Carvajee and